Good afternoon. My name is Chris Whitehead. I am with Siena Heights University, and this is a class on public speaking, and my topic I'm covering today is community paramedicine. Now, for those of you that don't know what community paramedicine is, it's a broad definition, but basically it's a paramedic or healthcare worker that goes into the field and does non-emergency work. They basically handle chronic care cases. So, backing up, this conference we went to explained to us about the Affordable Care Act. And in the Affordable Care Act, in all 20,000 plus pages, not one page, line, paragraph details how emergency medical services in the pre-hospital setting will be paid. So this conference covered another route that you may be able to take as a fund revenue to maintain your program. So the Center for Medicare and Medicaid Services considers readmit rates as excessive. Medicare spends between 12 and 15 billion in hospital readmissions a year, and that number is going up. 1 in 5 Medicare recipients are readmitted within 30 days of discharge, and then 1 in 3 of those are readmitted again within 90 days. So that's a little background into what was driving us to build this program. So in 2013, when we returned from the conference, we developed a mini proposal for our hospital. When we went to the hospital that we were hoping to team with, we identified several diseases and disease paths that are readmitted in the 30-day readmission diagnosis. And this is well known throughout the medical community. But one of them is congestive heart failure, CHF. The other is chronic obstructive pulmonary disease, pneumonia, certain heart arrhythmias, and infections, including kidney infections and urinary tract infections, which also lead into sepsis. And sepsis has become another strong word and patient type that we are treating out of hospital. So we went to the hospital, we gave them our little detail of what we discovered, and they were more than willing to work with us. So we formed a task force in December and January of 2014, and we began constructing what we felt was a plan that would work good for both of us. Now, the plan that we're building, there is no revenue for us at this time. So we realized that, but we felt that someday in the future, Medicare and Medicaid would come up with a plan themselves on how to reimburse to keep people out of the hospital. So as we teamed with the hospital, we sold ourselves as we are paramedics trained. The department I work for, we have 64 paramedics, 57 of them are on the road. We are trained specifically for field medicine, and we visit the homes. Mobility and flexibility were our hallmark, and our scope of practice is medically advanced and complementary to clinical nursing. So what we do in the field is basically, very basically, what a nurse can do in the emergency room, a nurse and a doctor team. And we also are very familiar with, in the field, how to communicate to the hospital our findings, our thoughts, and then the proper care plan in an emergency setting to get them to the hospital. So now we're going to take this to the non-emergency, handling chronic disease paths. And we felt that we could cover this with no problem and maintain it in our scope of practice as defined by the state of Michigan. So while the hospital developed the plan on their side, we started developing the plan on our side, which included getting our local medical control authority on board and then going through several committees at the state level. Ultimately, by February of 2015, we were able to be granted a 3-year study, and we were the only fire department chosen in the state of Michigan to proceed with this study. So now we were really going to get busy. So the hospital at the same time obtained a grant for the ability to use telemedicine when we visit the people's homes. So how we do it now, the hospital interviews the patient that's in the treatment floors, such as ICU, the general surgery floor. What they do is they go and they identify them through our zip codes in our area and determine that yes, you are a candidate for this program, community paramedicine program, which we named through the hospital. It's called remote specialized visiting physician. And what this is a virtual waiting room that we meet the doctor in and develop a care plan. So, backing up, the nurse interviews them at the hospital, identifies that they're a candidate for the program, gets them to sign into the program, and then once they're released, we see them within 24 to 72 hours. What we do when we go to the home is we do take basic vitals, we take an EKG of their heart, we weigh the patient, and then we examine their medications, make sure it matches up with their discharge papers, and then we follow through and make sure that they are following up with their physician. So to keep them out of the hospital is A, to make sure that you're taking your meds, B, make sure you're following up with your primary care physician, and C, that if there's anything else we can do to help in this care plan, ultimately what we're going to do is keep you from being readmitted to the hospital. The readmissions are where it gets very expensive for the hospitals, and this is where Medicare and Medicaid are paying out the most, and this is what they are trying to fight, or trying to develop programs to keep them out. So as a community paramedicine, what we found we've become is part public health, part disease management, part prevention, we are part social worker, we are an educator, and we are part treatment. So we have a broad definition of what we do. So the way we sold it also to the hospital is we were going to be non-competitive, meaning we weren't going to take a job away from an ambulance company or any home health care company. So we were going to be non-competitive, we were going to stay in the confines of our township borders, and we're going to design this program to fill in any healthcare gaps that we could fill in. We were going to provide primary health care, improve emergency response categories, and strengthen healthcare collaborations in our community. So in this plan, ultimately is to keep the readmits down for the hospital. Now, in those 1 to 30 days, the Affordable Care Act states that they will pay, let's say you go in to the emergency room and then you have to go to surgery. So if your whole hospital stay and visit is between $30,000 and $50,000, the hospital will be put on hold for that money. They'll receive a portion of that money, but not all of that money. And the big reason is if the patient is sent home and then in 30 days they develop an infection that's determined to have happened while they were in the hospital, then they will withhold that payment, and the hospital not only won't get paid for the first time that they had the patient and the patient contact, now the second time when the patient's brought in, they don't get paid anything at all. So it's a lose-lose situation. So what we're hoping to do is to keep the infection rate down, identify if there's going to be an infection, and then the doctor can prescribe the perfect or the medications to keep them out of the hospital. And our job is to make sure that they're following the treatment plan. So getting back to the telemedicine portion of it, the hospital purchased some equipment for us that has to do with meeting the physician online. So we go into the home, we do the basic patient assessment as I explained, and now we meet the doctor in the waiting room. So the doctor meets us. It's just like this. It's like Skype. It's like FaceTime. It's more like FaceTime. But we also have the capability to shine a camera on their wound, and we also have the ability to send what we see their heart doing to the doctor and to the hospital, and they can read a rhythm strip and see if the patient is progressing the way that they're supposed to. And then we can also do, we can listen to the heart and lungs, but at the same time we're listening, the doctor's hearing it also on his end. It has worked wonderful. So we get in, we do our patient assessment, we meet the doctor conducts a visit like if you were sitting in the waiting room, in the exam room, and starts talking to the patient. And what we found is by doing these face-to-face talks, people are great. They ask a lot of questions, and they have a good conversation. At first, they're a little worried. It's like the first time when you FaceTime or Skype, but it's a little awkward at first. But then they settle in, and then they have a good conversation with the doctor. And then between the doctor, the paramedics that are on the scene, and the patient, we develop a plan that includes the patient, and they feel confident in moving forward. So after we're done with the hospital, then we do a little home safety assessment where we go through and make sure they got working smoke detectors, working carbon monoxide detectors, and then a fire extinguisher in the home. And then also with the elderly, we are paying great attention to trip hazards, lighting, anything along that lines, entry to the home. But that's the basics that we try to identify in our community to keep them safe. So we don't have to go back there on an emergency. We can go back on a follow-up visit and just like have coffee or tea with them, sit down with them, and make sure they're following their plan. So in just a few cases we've had, we went to one gentleman's house. He was released from the hospital 3 days prior. He said he wasn't feeling as good as he thought he would be feeling. Between the doctors, the nurse, and us, we were able to determine that he had been prescribed double the medication that he was supposed to be. And he, had he continued taking this medication, his blood pressure would have dumped. We would have been there on an emergency call, and we would have had to take him back into the hospital. And ultimately the hospital would not have been paid for that visit. So not taking away from the money aspect of it, just the fact that we were able to help keep someone out of the hospital, make them feel better, and start their treatment to be to get back to normal, that was very rewarding. Another one was an infection that was starting to develop into a gentleman's leg. We were able to show the doctor that the knee, in this case, was warm and it was starting to redden. Well, they were able to prescribe him an antibiotic, got a hold of his pharmacy, were able to get the medications to him. He started down the road of taking that medication, and it kept him out of the hospital, saving him time in the hospital and saving the money in the insurance companies, the hospital and the insurance companies' money treating him. So ultimately, the goal of our system is to keep from unnecessary emergency room visits. The emergency rooms are overloaded. The wait times are horrible. What we're trying to do is minimize that at this point and make sure that people are healing better in their homes. Everybody's more comfortable being at home. They don't want to be in the hospital. We understand that. We want to help that. So that is our goal. Keep you out of the hospital, keep you healthy, and our motto is we want to deliver the right care at the right time and to the right place. Thank you.